Hello, I'm Ethan Sawyer. I've reviewed a case study for medical liability mutual insurance company titled Lack of Communication Between Treating Physicians is a Serious Detriment to Patient Care. This case was published by Kathleen L. Harth, Regional Claims Manager for MLMIC. The case presented the challenges that exist in the healthcare environment to effectively share communication amongst providers of care and patients. Specifically, you can see how hospitals and organizations have created policies to help drive, successful and effective quality care to patients. When these policies aren't adhered to, whether by mistake or timeliness, for whatever reason, it really leaves the door open for error and for bad things to happen for patients and in the delivery of care and for the organization. Some background and details on the case here is based on a 58-year-old patient who presented to an ER with a cough that they had for 2 days, as well as some pain around their rib cage. This patient was seen by an ED physician, prescribed a chest x-ray. A chest x-ray was read by the ED physician, and there was no radiologist on hand at the time. The next step was a misdiagnosis, as we would later learn, but the patient was diagnosed with pneumonia. And, within 24 hours, really the next day, the radiologist was able to read the chest x-ray. While they were in agreement that there was potential for there to be pneumonia, they saw different things on this chest x-ray, a density difference in the lungs, and thought there was potential for what they call neoplastics or cancer. Furthering the challenges of communication in this whole piece was that while there was a difference of diagnosis, really there's a requirement for a discrepancy report to be filled out here. It was never done. Further, this is challenged by the radiologist who filled out a report to pass on the information to the ED physician. That report was written to a general ED physician and not to somebody specific. He didn't address anybody. And so I think that really hurts the whole case here too. And really why there was a study done on this, and why there was eventual lawsuits that was brought against the hospital and the providers. They just really missed the opportunity to be precise. And when they aren't precise, just as anybody else, when you give directions to do something, they need to be specific if you need something done specifically. So not directing somebody specifically really created a bigger mess that had to be unraveled. And in an ED, I don't know, they really, unfortunately, don't have the time for that. And so nobody in the ED suffers, but the patient suffers. Later, we would learn in the article, this patient would re-present 6 months later with a worsening cough with sputum that was white, as well as tightness in the chest. It was at this point the patient was given a CT scan, and they could see a clear definition of borders around this lung, and there was nodules and things that were consistent with lung cancer. It's completely 6 months later. So pretty interesting. They really had the opportunity to provide 6 months earlier care. Not to cut to the chase, but this patient, several years later, expired, and it was, due to this disease that they had. A few things that we want to consider here is that the American College of Radiology encourages direct contact or intervention from the radiologist when the physician isn't present. Why didn't this happen was my first question. The next question that I have is, where doctors are limited for time, especially so in an emergency department, is there a better way to promote effective communication in a timely, quick manner to help this news get to them, make that a priority? And lastly, is there a way to tag the electronic health record to, by a radiologist to make sure that these systems between the hospital and the primary care provider are communicating. Is there a system that we can create to make this news maybe more rapidly get to the patient where they may not come back to the hospital for 6 months?